My talk today is about the approach to MSK pain internist perspective, and that include GPs. As you know, MSK is composed of muscles, tendons, bones, and joints. And for the sake of time, I'll concentrate on joints pain, especially the rheumatological manifestations leading to diagnosis of mainly autoimmune diseases, but other diseases as well. It's very common. MSK pain is extremely common based on a study that was done 2005 by Professor Adel and his colleague Adel Awadi. Probably most of you know him. They screened more than 6 people in Kuwait, and it was found that 35% of females having some sort of MSK pain and 20% of males having some sort of MSK pain. So it is really important to know where to go with these high incidence and prevalences of MSK pain. The most contributing factors are age, more than 50, and weight or body mass index more than 40, but all other age groups and other BMI are at risk of having some sort of MSK pain. The differential diagnosis is huge, whether rheumatological or other systems leading to some sort of MSK pain. Even among rheumatological causes, we have big differential diagnosis. And we know that the diagnostic process is not easy. It's very difficult for an internist or a GP to know everything about all other specialties. Indeed, the medical knowledge now is 200 times more than any human brain can handle. That's why I'm going to use what we call distinguishing diagnostic facts for polyarticular or MSK pain. And that is an experience-based techniques for problem solving. So if you have this fact or this information, it might help you to decide if this patient needs to be seen by a rheumatologist or any other specialty. So I'll go by these facts one by one. History and examination remains the most important component for reaching good diagnosis or definite diagnosis. The tests, as you know, they're just to confirm the diagnosis, not to make the diagnosis. And sometimes we use them for prognostic informations, but never to make diagnosis by just ordering ANA or rheumatoid factor per se. And unless the patient is having some deformities or joint swelling, the tests are useless most of the time. And that's why for example, the last ACR-ULAR criteria for diagnosing rheumatoid arthritis, if you don't have a witnessed swollen joint, you cannot use this criteria. So again, even diagnostic criteria, if you don't see a swollen joint for rheumatoid arthritis, you cannot use it. You cannot enter this criteria for this patient. Fact 2, autoantibodies are fuels. We look at them as rheumatologists as fuels that could be on fire or could be silent. An example of that, just to show you an example, if you have an antibody without having fire, without having inflammation, without having myositis, without having, for example, high ESR or CRP, they're useless. So we will not treat this patient. And we see that a lot in our practice. Patients come in with their rheumatoid factor or ANA being done, and they're high, and they have no symptoms. It's a stress for the patient, and it's a stress for the doctor, because we will have, lots of time reassuring that the patient doesn't have anything. So unless they have some sort of inflammatory process, we should not do antibodies, because eventually, even if they're very high, will not do anything for that patient. But if they have some inflammation, then we can treat these patients. So this is very important fact to keep in mind. Autoantibodies can be silent or can be on fire. Unless they're on fire, we should not use or do antibodies. Example of that, 20% of normal population will have rheumatoid factor being positive. Around 8% of normal population will have ANA positive, up to 1 to 160 titer. And only 15% of hyperuricemic patients will develop gout. So 85% of those who have high uric acid, they will be asymptomatic for the rest of their lives. Just keep that in mind as an internist or GP. Fact number 3, knowing inflammatory versus mechanical pain is very crucial. And I'm sure all of us know what are the difference between inflammatory and mechanical. And if the patient is having inflammatory pain, that's a very important part of the history to refer the patient for further investigation. And just to go through the differences very quickly, inflammatory increases with rest, especially the morning stiffness, improves with activity. The opposite for the mechanical, usually the inflammatory all ages, it's more common for the non-inflammatory in the old age, and the rest of the differences. That's why if you see a patient with inflammatory pain, it's kind of important to refer for further investigations and for further diagnosis. If it's mechanical, you can take your time, follow up the patient, and use other facts to assess the patient. Fact number 4, duration of symptoms more than 6 weeks are likely to be chronic or lifelong. If the patient is having pain anywhere in his body that goes for more than 1.5 months, that's a good referral for a rheumatologist, orthopedic, whatever. Because most of the MSK symptoms or most of the pain symptoms that human being will have will resolve within 1 to 2 weeks. So if they have pain that persists more than 1.5 months or more, regardless what is this pain, where is it, what's the type of pain, it's preferable to refer this patient for further investigation and probably proper diagnosis. Exceptions are when you suspect gonococcal, rheumatic fever, infective endocarditis, meningococcal, and probably some viral infections. And these usually will have, those patients will have other systemic manifestations. Fact number 5, the temporal pattern can help in making the right diagnosis. An example of that, migratory pattern, when the pain appears in, or arthritis appears in one joint, then it goes, then it disappears, then it goes to a different joint. That's keep us think of certain differential diagnoses like rheumatic fever, gonococcal, Lyme, etc. Additive pattern, when it appears in one joint, then it persists, then it happens or occurs in another joint, etc. And that's we see in rheumatoid arthritis and most of the autoimmune diseases like lupus and other autoimmune diseases, even reactive, which is very common. Intermittent or relapsing remitting is also common on autoimmune diseases, but especially the crystal and psoriatic arthritis, but also we see it with reactive, palindromic, rheumatoid factor, and periodic fevers as well. Fact number 6, in absence of trauma, involvement of the elbow and the ankle joints, it indicates chronic autoimmune disease. So if your patient's having these two joints involved, you highly suspect an autoimmune chronic disease. Joint distribution is very important, and most of us know that. But again, if you concentrate at the elbow and the ankle, if they're involved, it's a good hint to think about autoimmune disease and refer the patient for further investigations. Fact number 7, extra-articular manifestations are a great door for making the right diagnosis, especially the skin. And we have many examples of that. And I as you see here, I highlighted the most important or the most common skin presentations, like psoriasis. These are kind of rare to see. Probably livedo articularis is not uncommon, but psoriasis is common in Kuwait and probably common all over the world. It affects around 3% of the population, and 1/3 of these patients will have ongoing psoriatic arthritis with that. So psoriasis is very important factor or element of the history if the patient is having joint pain. So we should ask about it, and we should ask even if the patient is having family of psoriasis as well. Also, malar rash, eye manifestations, if the patient is complaining from blurred vision, redness, pain, that's an indication of autoimmune disease in the background. Also ulcerations, and rarely we can see systemic sclerosis, scleroderma. Because psoriasis is common, it's good, or it's probably important to have a look at the nails. If the patient is having these findings like pitting, keratosis, onycholysis, and having the some joint pain, there is a very high chance that he's suffering active psoriatic arthritis, up to 80%. So it's probably good to have a quick look at the nails of the patient if they're having some sort of joint pain, because if they're having just this, there is high chance that they're suffering very inflammatory type of arthritis. Fact number 8, red swollen joint have very limited differential diagnosis, either septic or gout, and maybe rheumatic fever. So if you see such a patient, it's really important to refer for further investigations and confirming the diagnosis. Fact number 9, inflammatory spondyloarthritis or ankylosing spondylitis is not uncommon. In the past, we thought it is rare disease. Now with the improvement of diagnostic tools, this is becoming more common to see. And a prevalence study in a population 2010 in US, it was found to be of a prevalence very close to rheumatoid arthritis, meaning it's common. And the reason behind that is using the MRI to diagnose very early sacroiliitis and spondylitis before you see any changes in the X-rays. So, and we did a study here in Kuwait. I performed a study on more than 32 patients looking at the delay of the diagnosis of ankylosing spondylitis and inflammatory spondyloarthritis, which is an autoimmune and very inflammatory and causes damage to the spine. And we found that the average time to make a diagnosis is more than 6 years in Kuwait. And most of the reason comes, or most of the time being wasted within the GP consultation. So it is very important, and the message behind this that we need to aware GPs and internists about spondyloarthritis, because these 6 years have caused a lot of damage to these patients. So what to remember? Only 2 elements which are very important. If you have a patient with a chronic back pain for more than 3 months and he's less than 45 years old, this is enough for us to refer him to a rheumatologist for further assessment. So please remember this message. Any patient with more than 3 months history of back pain and he's less than 45 years old before the onset of this back pain, I think this is good and enough reason to rule out inflammatory spondyloarthritis. And maybe it's important as well to know what's inflammatory back pain, but again, having only these 2 factors in the history will be enough for us, and we will be happy to assess such patients. Fact number 10, which is extremely important, Zyloric and Adenuric, and I'm using the trade names because they're very well known in GP practice. They are lifelong medications. So if you want to start the patient with Zyloric or Adenuric, please know the indications. There is no such, you give us such a case scenario that you give Zyloric for 2 or 3 months. This is a malpractice. This is wrong. So if you want to start Zyloric, please know the indication. I will not teach you today about the indications. If you decide to start the Zyloric, just revise that. Just read and try to remember, or try to read, does this patient need to start Zyloric? Because if you start Zyloric, it will be lifelong, and then you have to see him every 2 to 4 weeks to redo the uric acid and make sure it's less than 360 millimoles per liter, and to rule out hepatic toxicity as well. So, and I see that a lot in our clinics. Patients come with intermittent Zyloric, and we don't know what does that mean. So please remember this message. Zyloric is a lifelong medication, and we have to know the indications, and if we start it, we have to follow the patient to make sure that what we're giving is meaningful and to rule out side effects. Other messages, it's not to be used to treat acute gout. Okay, so it's to prevent the next attack. So it's the main message here, or the main use of Zyloric or Adenuric, is to reduce the uric acid so they will not have another attack. But it's not to treat the acute attack. And we should not, I'm sure everyone knows that we should not start Zyloric or Adenuric during an acute attack. Most important thing, and we still see that some patients or patients with hyperuricemia and having recurrent gout attacks, and they're already on Zyloric, when they have a new attack, most of the doctors in emergency, probably GP, will tell them, stop Zyloric. This is wrong. If they are already on Zyloric, we should not touch Zyloric. We should keep it as it is and deal with the acute attack with just non-steroidals and steroids, whatever is that. Because if you stop Zyloric during an attack, you will manipulate the equilibrium between the crystals and the blood more, so the attack will be longer. So if the patient is already on Zyloric and having acute attack, don't touch Zyloric. Let him continue the medication and deal with it as usual with non-steroidal or with steroids. And again, remember, gout occurs only in 15% of hyperuricemic patients, and 85% of hyperuricemic patients will remain asymptomatic. So most of those patients who are having uricemia and having some sort of joint pains, they have no relationship between the joint pain and the hyperuricemia. And we have to read again the indications for starting Zyloric. Fact number 11, ASOT link to rheumatic fever needs better interpretation. And I mentioned that because we see a lot of patients coming with their ASOT titer, and no one knows how to interpret that. Okay, most of us think about rheumatic fever, but remember, don't do it unless you really suspect rheumatic fever. There are some symptoms that might make you think about rheumatic fever or post-streptococcal infection. It's not diagnostic, it only allows you to use the diagnostic criteria again. And what's normal titer in Kuwait? That's a big question mark. The last time...
Dr. Ahmad?
Yes.
1 minute.
1 minute, okay. I'll do it very quickly. So the last time the normal ASOT titer was studied in Kuwait was 1982. A normal school students. And it was found to be, the average was, or the mean was 270 units, okay? So it was ranging between 50 up to 600 in normal population, asymptomatic children. So if you want to really interpret ASOT, if it's not more than 400 to 600, it's not important. So I think all of you know that the labs, they say if it's more than 200, it's abnormal. This is absolutely wrong, based on this very weak evidence. So unless it's more than 400 to 600, it is not that important. Fact number 12, small doses of steroids may be useful as a diagnostic tool while we're waiting to investigate the patient. Sometimes we just give a small dose of steroids and see if they improve. If they improve big time, like 80 to 100%, that indicates that this patient probably is having an autoimmune disease, and that's good enough to refer him for better investigations and diagnosis. Common remains common. The most common cause of pain is osteoarthritis, rheumatoid arthritis 1%, psoriatic arthritis 1%, SPA 1%. Radiculopathy is extremely common, and we see a lot of patients just having radiculopathy in their pain. And you know, disc diseases in the neck is extremely really extremely common. So if they have any pain in their hands, number one, they have a neck pain. If they do have neck pain, then ask more about radiculopathic symptoms. So keep that in mind. And the last one, polyarticular joint pain is not limited to rheumatic diseases. Of course, other diseases like malignancies and endocrinopathies are important. And I will conclude in that. Thank you very much.
Thank you so much, Dr. Ahmad.